exit interviews at drug shops for treatment practices, what the child had and what they got. And we also did a review of the treatment registers to see adherence to protocols. And we had a section where we actually observed treatments, although that's not here, but we can discuss. And this presentation is just showing you appropriateness of care and proportions of what was, how people were treated. So management of fever at the drug shop, which basically management of malaria prior to the intervention. Nobody was using in the drug shops either intervention or control rapid diagnostic tests. So presumptive treatment, and I will give a little those results. But 8 months after the intervention, 83.6%, a huge proportion of children attending drug shops in the intervention area received a rapid diagnostic test prior to treatment, and none in the control. And basically, if we just look at the treatment, the utilization of antihistamine combination therapy was actually almost 4 times better in the intervention area compared to the control. Management of pneumonia, which is cough and fast breathing. Also, no use of any diagnostics of respiratory time at baseline, and 55% of the children from exit interviews at the time, over about 3 weeks duration, received their respiratory rate assessed using a respiratory timer prior to treatment for the symptoms of pneumonia, and none is a control. And again, actual utilization of amoxicillin was or treatment of pneumonia symptoms was much better if we're just looking at use of amoxicillin for symptoms. That's not shown here. Diarrhea is as interesting, or very interesting, because at baseline, yes, people were receiving oral rehydration salts for diarrhea symptoms, about 15% in each of the districts, but nobody was actually, no child was receiving zinc tablets at baseline. And when we reassess this 8 months later, 76% of the children who reported having diarrhea in the intervention area received oral rehydration salts and zinc, and 5% in the control. So I'll give you a brief overview on what we found in the registers. And remember, we also observed this treatment, so the findings are pretty consistent from observation and using records in the registers. 7,000, almost 8,000 children were seen during this 1 year period in drug shops. And fever, children about slightly over 6,000 presented with fever, and almost all the 6,000 actually had a rapid diagnostic test. So this is only in the intervention area. All of them, the positivity rate of malaria rapid diagnostic test is pretty high, about 7 out of 10 were positive, and that's true. But then still, almost all who were found to be positive with the malaria rapid diagnostic test received their antihistamine combination. Pneumonia management, again, we had about over 5,000 children presented with cough and symptoms of fast breathing, and most of those were respiratory rate was assessed, and about 2/3 actually were diagnosed with having fast breathing, and most of these received their amoxicillin. So the diarrhea graph is just as consistent with from the exit interviews that on 2,000 children, well, maybe 2,300 represented with diarrhea during this 1 year period. Almost all of them received their oral rehydration salts and zinc in the intervention area. And I like to show this slide. It's still in the intervention area that showing care, first point of care for these febrile children in this area. Management at home, both at baseline and after the intervention, remained about the same. Utilization of a health center as well. This is drug shops in the purple, our registered drug shops, and this was other private sector, which in this area was unregistered drug shops and anything else maybe. But we saw no changes in actual home care, and this can be discussed, and access, utilization of the health centers, but a huge shift from people who were attending unregistered drug shops and getting some medication somewhere to registered drug shops where our intervention was. And we conclude, I mean, again, we are finding that there was expanded access to diagnostics and the recommended treatment at these drug shops when we introduced this iCCM strategy. And there was, we found adherence or high adherence to the treatment protocols by the drug sellers. And they conclude that iCCM could be utilized to mainstream drug shops in these areas where both the public sector and private sector are highly utilized. Thank you. Those are funders and the children in the district.
The translation works for Spanish. No? Yes? No. Well, I'm bringing a bit of bad news. My name is Javier Bosch-Kaplan and I'm working at the Swiss Tropical Public Health Institute. I was especially interested in the South Sudan presentation because that was my first real contact with tropical medicine when I was some years ago. And actually my second work was in Ghana, in Upper West, in the last hospital that you could find going towards the north, close to the Burkina Faso border. And actually, Dr. Apiade Kira, who will close the symposium, was my boss there. He was the provincial director in Upper West. But I came here because I was invited by UNICEF, and I thank them very much. And I thank especially Michelle, Abigail, Alexa, and some others who have been helping me and my team in Switzerland to do a structured review of 26, 29 iCCM projects. What we did was to collect the information that was made available to us, read it, and try to synthesize what were the main characteristics of those projects, and also try to extract from those documents evidence on the effects of these projects. So, yeah, yes. So here I would like to, or I have been asked to talk to you briefly about some of the problems that we have found, which is essentially the type of evidence, type of information that we have found, and how can we extract some useful conclusions about it. And I will not tell you anything new, but I want just to emphasize, this will be the top of the agenda for today, if I can, this issue. Basically what we want in anything like iCCM, malaria control, any intervention, any disease control, any aspect that we want is to have good outcomes so that people live better and longer. We achieve this only if there are good decisions. So if policymakers, if managers, they are taking the correct decisions at everyone. And we can only do this if we have evidence. Research evidence, but also other types of evidence. But anyway, research evidence as well. If the underlying evidence is biased, there is no way that you can have a sound decision. There is no way. There is no way. Because the evidence is biased. If you don't have a good decision because your evidence is biased, there is no way that you can have a good outcome. You may like this, you may dislike this, we may judge it, or that's painful or isn't painful, but that's the thing. When I say bias, and here this is something that the statisticians know very well and is very useful. One thing is bias, the other thing is error. When we are measuring things, when we are measuring impact, when we are using quantitative or qualitative methods, it doesn't matter. You have some error because of your methods. Your methods have some limitations. The beauty of statistics, we know that this or we don't know that this, it doesn't matter, we just need to have the phone number of the statistician. But the beauty is that this type of error, this type of measurement error, you can estimate it. You can know how likely are you to be very far or close to the real measurement. So if you say that 25% of medical workers have done this or that, and you have done this properly, you can know whether your margin is 20 to 30 or 10 to 50 or 24 to 26. When you have bias, for example, because you have selected communities using your finger instead of a randomized thing, or just because you use communities which are closer to your place of work, or communities who have traditional leaders who are more pushy for you to work with them, then you're introducing bias here. And the problem of bias is not that you are not in the exact place, that you are not in the exact measurement, because that's life. We never get anything exact. The problem of bias is that you don't know at all what is the difference between your measurement and reality. You can be as close as this, or you can be as far as this. So what we want is to avoid bias, and we can avoid bias. Yes, we can. But what we cannot avoid is error. But that's fine because we can measure, we can estimate. So when we have been reviewing all these documents, the essential question, the syntax of the question is, or well, I should have formulated this as a question, but are iCCM programs effective in improving treatments? So for answering this question, the first thing that we need to know is what is iCCM. And from my perspective, which is an outsider from this topic, but from my perspective, I have not seen a standard definition that everyone is using. Therefore, what you are measuring is completely different from what I measured, or could be completely different. Then, are iCCM programs? Well, which programs? My program, or all programs in the world, or all programs in Sub-Saharan Africa, to which extent what I'm saying about my program can be representative of other countries or at a global level. When we say our iCCM programs are effective, what do we mean by are? Do we mean that iCCM programs are the cause for the outcomes that I see, or are something that helps, or something that doesn't disturb? To which extent, which is the level of the intensity of the link between our program and the outcomes? When we say are effective, well, obviously they are effective, or easily they are effective, but the point is whether they are effective more or less compared with something else. Because we already, without iCCM, there is some type of health system, there is some type of health service running, health service running. So if you want iCCM, you have to say that it's more effective than something else. Otherwise, it's or cheaper, or and then for improving treatments, or what are the outcomes, and not only the outcomes, the good outcomes, more health, but also the harms. For example, costs. Or for example, as I was reading in one of the programs, there was a program that was or suggested that as a result of the iCCM program, less people were using traditional fillers. And this was seen as a good outcome. Well, is this a good outcome? So, and then I don't want to disturb you with this slide, but basically each one of these issues that I have been raising can introduce bias. For example, I will only report on those outcomes which show benefit, and I will not tell you about those outcomes which do not show benefit. And this is not because of bad faith. It's just because one thing that we can do very easily is to test 100 outcomes, and of course, only by chance some of them will be statistically significant. So the more outcomes I measure, the more likely that I will get some statistical significance, which I will put in the top of my results. Not because I'm insisting this, not because of bad faith. It's not that I'm trying to lie to you, but simply I'm interested in this topic. And then I try to tell you the nice story of it. That's normal. But we have to be a bit constrained here. So the good news is that there are several good news. But the good news is that obviously, as you know very well, and before you ask me this or you put this in the table, I want to defend myself. The question of effectiveness is not the only interesting question. You may ask, is this effective? But also you may ask, how does this work? Or is this acceptable? So there are many other questions. But certainly what I wanted to talk here is only about the issue of the question, is this effective? Does it work? Then you can have complex interventions, as probably iCCM is, but this doesn't necessarily mean that you need complex evaluations. Think, for example, that there are some of the